Any questions from the first half? Nothing at all. All right, so let's continue on with lecture 17. So we're now going to understand the quality of data in clinical medicine. This one's, I think, a little bit more interesting, but let's talk about data collection and analysis. Let's say you order a lab for a patient, say you order a Chem 7, and you get the results back. Now, you might think, are those results accurate or are they inaccurate? It's coming from the lab. You would probably assume it's accurate, right? I think for the most practitioners, if they get a lab result back, they assume that it's going to be accurate. Is that always the case, though? No, right? There always can be random errors. It could be bias. It could have been run incorrectly. Maybe someone accidentally was eating over the lab equipment and spilled some I don't know, ketchup or something. I'm smelling a lot of hot dogs out there, so I'm kind of thinking that. Anyway, so we do know that there always can be some inaccuracy in our tests, and so it's important to kind of understand that because, again, if you're making a diagnosis, if you're trying to choose how well a drug treatment is working, if you are, I'll give you a good example. So I was on call the other night, and we had a patient who was bitten by a snake, and it was actually 24 hours out. I think it was like a pygmy rattlesnake or something. And basically, we had to make the decision. One of the things you'll see with pit viper envenomations in Florida is that coagulopathies are a common complication of them, right? So you can see things like their coags will start to increase, their fibrinogen will start to go down, and there is risk for bleeding. And so we basically had the lab results that came back. And again, we're dealing with all the hospitals basically in north central Florida. So we had, based from the Panhandle down just north of Orlando, so there's a lot of different hospital systems we're working with that may have different qualities in the lab, right? But basically the specialist called me up and said, hey, here are the lab results from this patient. Do we need to give more antivenom or not? And so he gave me the lab results, and I just take them to be the holy gospel. I assume that they're all accurate, right? And that's important because we then made the decision to give more antivenom. And I don't know if anyone knows, but antivenom is quite expensive. For, say, instance, I think the last time I checked it, I think it's something like $1,600 per vial, and I think we recommended 4 vials. Right, it's expensive, but basically the labs were showing me that they were going in the wrong direction. They started to, PTINR was going up, platelets were going down, fibrinogen was going down. It looked like you really needed it, so we made that choice. But again, I was working under the assumption that the lab is correct. But keep in mind, not every lab test is necessarily going to be perfect out there. And so again, when we're saying error, we're not talking about medical mistakes in this case here, but we are talking about what the difference is between what the actual true value of something is and what the observed value is, right? So for instance, if you were, say, checking for heart murmur, you're checking the wrong spot, potentially you may get inaccuracy with that, right? If you're getting a laboratory result back, perhaps if they ran it incorrectly, you can end up getting the wrong result. So anyway, so in those cases there, you make that decision. So again, if I have a patient who's coming back with abnormal coags, then I would make the assumption that yes, he's having a coagulopathy, right? That could be a false positive in those cases there, or it could be a true positive. But if it came back and everything looked fine, I could say, well, maybe he doesn't need antivenom, which is called Crofab. And that may be, if they're incorrect, then maybe it's a false negative. So we always know that there is going to be a risk with these, and we'll talk more about those, especially when we're talking about how we actually diagnose patients. Okay. Ideally, though, we'd like to minimize errors in our data. Hopefully, they're going to be as close to the actual values as they can be, right? And so there's kind of 2 terms we'll talk about, which you probably have kind of heard this before, but in terms of accuracy and then precision, right? So when I say accuracy, what does that mean? How close it is to that true value, right? So we always think about like a bullseye, like a target, saying, okay, well, how close am I to the middle there, to that actual bullseye, to making the actual true value there, okay? However, you may find that the data is not accurate. Maybe it's biased towards one direction or another. Say, for instance, you're doing a study where you're measuring temperatures in patients, and you're supposed to get oral temperatures every time. We have one researcher who is measuring data, say, temporally, or measuring temperature temporally. That might skew your data one way, right? That makes it inaccurate. Precision, though, is what?
Getting the same result.
Likelihood you're going to get the same result every single time, right? You may be wrong every single time, but it's at least precise, okay? And so you're going to find that some tests are very accurate, but maybe not very precise. Maybe you get some variability in the actual results you get, even though they're pretty close to the real one. You may find examples of things that are very reproducible, very precise, but they're just skewed one way or the other, right? So for instance, in that case there, that same researcher would get very similar temperature readings, so they'd just all be wrong because they were done temporally instead of orally, right? So again, this is where we're going to be kind of focusing on that. Notice here you can have sort of combination of any of these. So you can have both accuracy and precision, where you expect if you're getting that same value and measuring it over and over again, that it'd always be the same true value. Versus if it was accurate but not precise, you'd see there's a lot of variability in the data, right? So it'd be a much wider curve. If it was precise, you'd find that the true value, even though it's kind of being precise, just wrong, versus the true value, which we're going to find here, if it was neither precise nor accurate, you'd find, again, it's just not even close to the mark, right? A lot of variability, and it's not even close to the right answer there. The other way to put this, and kind of make a little bit more sense graphically, would be if you had something that was both accurate and precise, you should be getting pretty close to the right answer every single time, consistently. If it was accurate, but it was not very precise, you end up seeing this more like kind of a buckshot sort of pattern here, where, again, everything's fairly close to being correct, but you can find that it is a lot more variable in terms of those results you get there. If it was precise only, you can see here that they just totally missed the mark, even though it's very consistent when they're getting those results. And then if it's neither accurate nor precise, which is the worst of both worlds, you can see they're not even hitting the target. This is probably what it would look like if I ever went to a shooting range, I would imagine. But there are different types of errors here, things we can do to try to help prevent these. But when we talk about measurement bias, that's what we call a differential error. That's something that's going to be non-random. It is systematic. In that case I mentioned, someone's measuring temperatures incorrectly. That would be considered to be a measurement bias, right? It's going to be wrong the same way every time because that person's doing it that same exact way. If I were to say measure patients with their shoes on versus off, right? That can introduce that sort of bias there. Everyone would be reading too high compared to if other researchers were measuring them without their shoes on in those cases there. Again, is there any statistical analysis I can do to fix that? Well, it's kind of the idea of garbage in, garbage out. If you put in bad data, you're going to get bad results out of it. There's no way the statistics can kind of play around with that, right? And so even though we could measure those patients with just their bare feet, measure the height, it does not eliminate the random errors, though, right? It does not eliminate the fact there is some variability in patients. These are what we call non-differential errors. And so, again, if you're looking at the data, you're going to find that if it's just due to random chance, you're going to find that some observations may be low, some will be high, but they tend to cancel one another out. Things tend to regress back to that mean there. And so in those cases there, that's why we do things like randomization. That's why we try to randomize groups of people into different categories there, so that way we can say, well, both of these groups, both treatment and control, they are quite similar to one another, even though they are different. Things typically average out. So the age should be similar, the gender should be similar, etc. So when you look at these studies and you actually look at the actual patient demographics, they'll look at the two groups there and they should look fairly similar in terms of their different stats. That's how we try to get rid of some of that non-differential sort of error, that randomness out of the data there. Okay. So there's terms of what we call intra and inter-observer variability, and this is a big thing to consider, especially with like retrospective chart reviews and things like that, where if you're thinking about intra-observer variability, this is going to be with differences in the measurement of people obtaining it. So for instance, if someone were to say take successive measurements of blood pressure on the same person, or said they examined the same x-ray several times without knowing it's the same one. Presumably if you got the same x-ray over and over again without realizing it, you should presumably get the same reading on it every time, right? Or if you were to measure someone's blood pressure manually, you should presumably get the same blood pressure every time. However, maybe they mess up their technique, or maybe they read it incorrectly, something like that. That would be called intra-observer variability. Hopefully you'd assume the person would do it the same way every time. What you end up running into sometimes, though, is what we call inter-observer variability, where you have people doing things differently and getting different results there. So for instance, if you have two different clinicians who are measuring the same person's blood pressure but they get different results, or if you had this two people reading the same x-ray but they came up with different interpretations, okay? So we call it inter-observer variability. Now how do you think we could deal with that? How do you think we could try to mitigate some of that bias? Usually training is a good way to do that, so make sure people are trained on how to do things the correct way every single time. Obviously that only goes so far. In some cases there's actually statistical tests you can run to look at the differences in the actual results to show that, hey, our two observers were doing things very similar to one another, right? There's ways you can do that, and so sometimes you'll see that actually listed in the literature there. So one way we can look to decide whether we think, say, a screening test or a diagnostic test is useful to us is to think about it in terms of two different groups, right? So when you think about a laboratory test coming back, you can consider either normal or, say, abnormal, right? Kind of broadly speaking, you consider it one of those two ways. And then we'll have people that either have the disease we're trying to diagnose or they don't have the disease, right? So we're going to be looking at these 2x2 tables here coming up and trying to determine how well performing our actual diagnostic tests are. And so we're going to see that presumably if you're running a test and it comes up abnormal, the patient should or should not have the disease. They should, right? And if the patient has a normal value, they should not have the disease, right? Makes sense. Now, is that always the case? No, because we know there's false positives, we know there's going to be false negatives there, okay? And so you'll see that a lot of different factors can come up that can maybe introduce some bias into your results here. So say, for instance, maybe the stage of disease, maybe it's not progressed far enough for a result to be abnormal. Even though they have the disease, that can certainly affect it, or maybe just the spectrum of disease in the whole study population can be causing some issues there. So again, it's important when you're actually looking at your laboratory data and comparing it to the patient to see, well, where did this actual information in terms of what's normal, what's not normal, where does that come from? What kind of characteristics are they looking at of that population? So, for instance, you can look at the stage of disease, how that might affect your results. So imagine you have someone who is very early on with their infection of, say, HIV or TB. Are they going to test positive immediately after infection? No, they will not. All right, so in that case there, if a laboratory test comes back normal, even though they have the disease, what do you call that? It's a false negative, right? Because they tested negative even though they have the disease there. But that's understandable because we know that early on there's no immunologic evidence of infection because, again, it's just too new for those patients there. So in those cases there, due to early, you get the false negative test results. Which is why sometimes, say specifically for like, PPDs and things like that, you've heard like a two-step PPD. You never have to get one of those, right? Sometimes they try to do that to make sure, even if the first one was negative, they want to make sure it's not a false negative, and that way they can do a second round there. And so again, it's important to know when you're kind of looking for the potential usefulness of a test, what that spectrum of disease is, because you'll find that false positives and negatives can really be quite a big problem there, right? And so as I mentioned in the case of the tuberculin skin test, let's say they have false positives, tend to be more found in people from the southeastern U.S. Where do we live? Southeastern U.S. Oh no! This is actually an old way of testing for TB that as we'll find here in a second. Basically, though, back in the old way they were testing for TB, they actually found that there was other type of mycobacterium that were living in the soil that would commonly be sort of a contaminant, so to speak. There's cross-reactivity there, so it would look like the patient had TB, even though it's really related to sort of a completely separate mycobacterium. And so you got a lot of false positive results, right? And so if you got a false positive on a TB test, or you had a patient who had a false positive test, they think they have TB now, which is not great. So, and then you got to do follow-up testing. So that's when we end up changing. We realized that patients were going to have more likely to have this false positive result, so we were able to switch to a different test. This is why we now use the PPD, which is that purified protein derivative. And how do we tell if a PPD is positive or negative? How red it is? No, it's in duration there, right? So you'd be seeing that, okay, if it's between, say, 5 and 10 millimeters or more, consider that to be the case there, right? Or maybe because in some patients, maybe due to, say, immunocompromisation, they may not be able to mount a very good response to that. In those cases there, you may get a false negative, even though they may have TB, right? However, what are some cases for false positives for TB? Anyone know? Yeah, if you ever received the BCG vaccine, which some patients who are maybe were not born in the U.S. and might have gotten it in other countries, we don't typically give it here, but they will show up positive. I remember I had one classmate in school, and I'd never seen a positive PPD before, but he had the BCG vaccine, didn't tell the people who were given the PPD, and went ahead and got it. I mean, it looked like a paintball just like welted on like a point-blank range. It was huge. But that was okay. That was a false positive for him. He just knows he has to go get a chest x-ray, and that ruled that out, right? And again, this was good because, again, it will help to limit the false positive by switching over to this new test. So we know there's going to be a trade-off between two terms here, which I think are going to be quite important for this lecture set, what we call sensitivity and specificity. Okay. So anyone know how you could describe sensitivity?
Ability to react.
The ability to handle someone being your doppelganger for a day? Perhaps. No. So what is sensitivity? The ability to detect the disease if it's truly there. Okay. So that way, if you have the disease, you should be positive, right? Actually, I took a blood test the other day. I got an A+ on it. So in contrast to that, Some of you took a second. It's okay. Anyway, so for specificity, though, what is that?
Only goes up with the one you're looking for.
Okay, I'm trying to think of another way to put that.
Sorry.
So if you don't have the disease, you should be negative. So how good is it actually being able to say if you do not have the disease, it's going to stay negative, right? So you're going to see that this is going to be intrinsically related to false positives and negatives when you're comparing the sensitivity and specificity of different tests together. So for instance, if you have a fire going off in your home, would you want your fire detector to go off, your smoke detector to go off? Presumably yes. Do you want it to go off, say, when you're cooking a bag of popcorn? No, right? So you want to be sensitive to be able to pick up when there's actually a fire happening, but you don't want it to be so sensitive. And you're going to see there's a trade-off between sensitivity and specificity. You don't want to do that go off with a lot of false positive alarms, right? It's like, I get it, I accidentally overcooked the popcorn, you don't have to remind me, okay? One of the trade-offs to having a home, if any of you ever get the opportunity to buy a home, is that you typically have a lot more fire or smoke detectors than what you're used to. And so when one of them invariably has the battery go out, then you got to figure out which one it is. And so it's usually, the time frame for that happening is generally between, say, 2 and 4 a.m. And then I had to stand around there like an idiot going, is this the one? I had to wait 30 seconds, wait for it to beep. No, it's not that one. Go to the next room. That one? Not that one. Okay, that's true. Not great. Anywho, make sure to change your batteries off on your smoke detectors. Don't want to die from that. Okay, so again, looking at the ideas of false positives and false negatives, again, it's not just related to infectious disease purposes. So we're going to look at the idea of using serum calcium levels to help us diagnose hyperparathyroidism as an example here. So again, like when you're looking at, especially when a lab results gives you some results back, they'll typically give you a reference range on there, right? So I'll tell you, this is what the normal range should be. Now, does that mean that every patient that goes outside of that range is abnormal? Not necessarily, right? You got to think about, most of those tests are looking at sort of 2 standard deviations away. You only get 95% of that population typically. So again, some people are normally abnormal, so to speak. And so in those cases there, it's also important, like, where do they set those cutoffs? How do they determine what the proper set point is to say this is an abnormal lab result? And so we'll get into that in a little bit. Now, again, patients with hyperparathyroidism, their calcium levels are usually high or low? Usually high, right? Because parathyroid hormone is going to cause calcium to be leached from the bone, try to increase calcium levels, and so you'd expect them to have high calcium levels, right? So you may, though, find is that the only reason why patients would have hypercalcemia? No, there's a lot of reasons why patients could have hypercalcemia, right? Maybe they're on a thiazide diuretic, perhaps. Maybe. A lot of different reasons for this. So because of that, you can find that just basing a diagnosis off of a single calcium level may not be the best way to make that diagnosis, but we'll look at how that can be useful for us in terms of kind of relating it back to false positives and negatives. So basically the next figure is going to show you the frequency distributions of serum calcium values. It will show you patients who are without hyperparathyroid disease, without parathyroid disease, I should say, and then the other is going to be showing you the calcium levels for patients with hyperparathyroidism, okay? And so we're going to look at the two between them, and you're going to be able to see kind of the comparisons between the two in terms of how the overlap occurs between the levels there, and you will see that there's some degree of overlap, right? So, and again, presumably a high level would lead you to think that they would have hyperparathyroidism, a low level would lead you to think they do not. So if you were to look at this, looking at the non-disease population, which is going to be curve A, versus curve B here, which is going to be the hyperparathyroid population. And so what you're going to notice here is that what if you got a value, say, that was a 10.8 or something? The cutoff here for this test they would consider to be 11. And if the patient with hyperparathyroidism had a level of 10.5, you would incorrectly assume that they don't have disease, right? So is it reasonable to just use just a single calcium level to tell you if they have something? Now, again, if it's obviously, if it comes back and it's 13, it's very unlikely to be normal for that patient. If it comes back at 9, probably unlikely to be hyperparathyroidism. So the extremes are easy enough. It's when you get into these little gray zones in between that it can be much more difficult, right? Sometimes you need backup testing to confirm this. Sometimes secondary testing, say do the same test serially, sometimes can help you out. But we'll kind of look into those details as we go forward. And so again, laboratories will publish that range, what they consider to be normal value, so to speak, and then anything they consider above that, the reaches above that, 11 in this case, they consider to be abnormal, and it will flag you on your computer systems you're going to be working with there. Most places will generally put calcium around 11. It's considered to be the high end of normal. So, but if we set, what happens, say for instance we were to set that calcium level, say the abnormal high point, down to say like 10. What would happen in those cases there, do you think? You'd have more people that are flagging as abnormal, right? You'd be more likely to think, oh, something. Now, we mentioned, looking at that slide, are some of those people with hyperparathyroidism, do they have levels that low? Yeah, so you still may be able to capture, that net might be wider to capture people who maybe actually have a true calcium disorder of calcium homeostasis. However, you're going to have a lot more people that are flagging abnormal when really they're not. What do you call those? False positives. Yeah, so generally the lower you set your trigger point for, the lower you set your threshold, the more people you're going to be picking up, the more likely you are to get false positives. Okay, that is increasing the sensitivity of a test. So that way, if it comes back positive, well, it could either be really positive or it could be a false positive, right? And so we're going to be looking at a trade-off between those. Because again, I could set the, say, a calcium level of 1 is abnormal, high, right? Because at that low, and then everyone triggers as being high. I'm sure to get everyone has hyperparathyroidism, but I'm also going to be getting a ton of false positives. So again, there's a utility between that. You have to kind of figure out what that right spot is where it's going to be able to capture the majority of people. Maybe not everyone, but most of the people have the disease, and it's not going to be set so low that I'm going to get so many false positives. I got to then get expensive tests to work up every single patient with a, say, calcium of 10, right? What would happen if I set the trigger point even higher? What if I say I set it to 12? What would happen? I would be missing cases of hyperparathyroidism potentially, right? So by setting it up higher, my threshold is higher to meet that case of to be considered abnormal, such that I may have more false negatives, right? I'd be missing people that actually have the disease, okay? Again, you're going to find that every test has a trade-off between sensitivity and specificity, and we'll talk about how we utilize those in sort of a sequential sort of manner there. So from that, we can also determine what we call the positive predictive value and negative predictive value. Basically saying if a test is positive, what is the likelihood that patient really has the disease? And similarly, if it's a negative predictive value, if it's negative, what's the likelihood they really don't have that disease? And we'll kind of get into that when we get into the big table here. So, as I mentioned, sensitivity and specificity, very important points here. And there are ways to kind of tell you what the performance of that particular test is. How good is it at picking up patients who have the disease? How good is it ruling out disease in those patients as well? And so we'll look at it in this 2x2 table, which may look kind of terrifying to some of you. Don't worry, we'll work through it. All right? I know it's Friday afternoon. You're thinking, I just want to get out of here. That's okay. So let's look at it. Plus, they gave me the whole afternoon block, too, from 2:30 to 4:30, so I don't want to get through the whole lecture material. No? Okay, we'll figure it out. So it's pretty intuitive once you start to kind of work with it a little bit. So let's say here we look at the test result is going to be on the vertical column here. We're going to have the vertical column's kind of redundant. But on here we're going to see these columns here are going to be disease versus non-disease. So let's say just magically we knew who really has disease and who does not, and then look at the positive versus negative rates here, right? So presumably if someone has a positive test result and they have the disease, what do you call that? The true positive, right? If they are negative and they have no disease, they would be considered a true negative. What would case B be here, where they have a positive result but they're non-diseased? False positive, and similarly C would be false negative in those cases there. So what we can do from that information is we can figure out what the sensitivity, specificity is, and also what our predictive values are going to be. And we'll go through each of these individual ones here. Again, am I going to have you calculate this on the test? Unlikely, but you need to understand what this actually means in terms of conceptually applying it to laboratory testing and when you're really ordering labs for your patients, right? So looking at this, we're going to see that the first column is going to be representing all the patients with the disease. So if they have a true positive result, they're going to be in box A. If they had a false negative result, they're going to be in box C, okay? Second column, as we mentioned, B is going to be the false positives. D is going to be the true negative cases there. And so then what you're going to find is also we can use the total amount of people there in order to calculate our prevalence, right? And prevalence is just what? The number of people with the disease at that given time there, which makes sense. So again, all the people, how do you get prevalence out of this? So you take everyone in the disease portion here, so A plus C, and then divide that by what? The total number of people you're looking at. So it would be A plus B plus C plus D, right? So you're basically getting what percentage of people out of this group actually have the disease. That would be considered the prevalence, right? Again, sometimes it's a little difficult when you're working with the variables, but conceptually I think you understand, okay, it's the number of people that have the disease in total over the total amount of people I had, right? So anyway, so sensitivity is basically going to look at and tell us the ability for the test to detect a disease when it's actually present. So we're going to be seeing here is basically going to be A divided by A plus C, which means we're going to be the number of true positives over the true positive plus let's see what C was. C is going to be our false negatives, right? So this is basically saying of all the people that we're testing actually have the disease, how many of them actually had that? So A divided by A plus C here, okay? So they test positive. What's the likelihood they actually have that disease there? What is the actual percentage there? You're going to find that if the test is not very sensitive, then it's going to fail to detect those patients there. Maybe your set point is set too high, and you're going to find there's going to be more people that fall into that false negative sort of category there, right? If you're not true positive, then you're false negative, as it turns out, if you have the actual disease. And so by looking at that, it's important to make sure you have the correct denominator, otherwise you can kind of goof up the numbers a little bit there. Another way we can call this, though, is by using correct answer we call it the false negative error rate. Is going to be all those people who are diseased but we kind of missed, essentially, right? So the number of people who did have the disease but the test came back negative for it. That's called false negative error rate. Typically, what you're going to find is that the sensitivity plus the false negative error rate should equal up to 1. That makes sense, right? So basically, everyone who has the disease, if you're not in the true positive, then you're in the false negative category. Okay, so that should equal to be 1. So specificity, that was mentioned, is the ability to say if that test comes back negative, you really don't have the disease there. And so you're going to have your true negatives divided by the number of people that don't have the disease in that category there, right? So that's why D over B plus D in that case. And so if a test is not very specific, then if it came back negative, you'd end up finding there'd be a lot of people that actually did have the disease, right? So it'd be incorrectly saying, nope, they don't have it. What kind of error is that? So this is going to be false positives. So you're saying, okay, well, they actually, but they came back positive, they actually did not have the disease, right? So you're trying to correctly identify those that don't have the disease there. So you have to look at comparing the false positive error rate plus the actual specificity of the test there. And again, both of these should equal up to be 1 when you add them together, okay? So let's look at an example here. Let's say we have 80 consecutive patients. They're coming to the endocrinology lab, and they're going to get their serum calcium level taken here for a hyperparathyroidism workup. Okay, this works better when you actually have a real example we can look at. And let's say our cutoff for normal is going to be 11. That's the upper end of normal for our test here. And levels greater than 11, we consider it to be positive, and then levels less than 11 would be considered negative. Okay. So let's say we knew that 12 of the patients here tested positive, they had the disease. 8 that had the disease were negative. You're going to see that of the non-disease here, you can find that 3 of them were positive, 57 were negative, and you get your total of 80 right here, right? So what was the prevalence of the disease in this group? Right, so 20 divided by, so the total number of people with the disease is 20 divided by 80, so that's 25%, right? So our prevalence of disease was 25% in that case there, right? So then how do we end up getting what our sensitivity is? So basically what you're going to be taking is our positive rate of true positives divided by the total number of people with the disease. So it's basically saying, like, what is the percentage of people that had the disease that actually showed positive, okay? And that ended up being 12 divided by 20, so I had about 60% sensitivity. That sound pretty good? That means that 40% of the people that actually had the disease came back negative on the test result. Not great, right? So, and then looking at the specificity, right, it's really saying that if you don't have the disease, you come back negative. So looking at this, the number of people without the disease that tested negative, so true negatives divided by 60, the total number of people without disease, comes like 95%. Is that pretty good? Fairly good, right? You like to get as high, close to 100% as possible, but every test is not going to be able to do that, right? Now, we can also kind of get up and figure out what our false positive error rate is. We know false positives, where you say the disease is there, but it's not. It's a type 1 error, right? We talk about that's kind of a false positive. So in this case here, positive result in someone without the disease is 3 divided by all the positive results, so 3 divided by 15. I'm sorry, 3 divided by 60 would be the total number of people without the disease, excuse me. You guys gotta check my numbers sometimes. Make sure I'm staying honest. So this would be the number of false positives developing here. The number of false negatives, so the false negative error rate is basically going to be 8 divided by that 20. So you can see here, The false negative error rate about 40%, so again, not great. I like that number to be pretty small if you can. And then we'll talk about predictive values here in just a few moments, and then we'll also talk about likelihood ratios in just a little bit, so we'll get more details on those. So again, you're going to find that sensitivity and specificity are interesting. They're kind of helpful in and of themselves, but they don't really answer these two questions here, right? So if a patient's test result is positive, what is the probability that they actually have the disease under investigation, right? That's what you really want to know. If this test comes back positive, what's the likelihood they actually have it? And then if the test result is negative, what's the probability the patient does not have the disease? Because you need to know, do I need to do further workup or can I stop here, right? So if that's negative, then it's okay, I ruled it out, I don't have to worry about it anymore. If the test is positive, say, okay, I got my diagnosis. Ideally, that's what you like to do. And so we can do that by using our sensitivity and specificity, and that way we can actually come up with our predictive values. It's going to help us out, right? So essentially what you're going to do is get this positive predictive value, and if you notice here, it's going to be looking at the number of true positives over all the people that had a positive result. That's going to give you the positive predictive value. So ideally, a bigger number here is going to be good because you're saying, okay, well, if they have the disease, the more likely to end up getting a positive test result, right? Versus when you're looking at the negative predictive value, again, this is good for ruling things out in this case here, because you're saying if it's negative, then it's really negative in that case there. So you're going to be looking at all the true negatives divided by all the people who had a negative test result, okay? So instead of using as your denominator all the people with disease or without disease, kind of doing a vertical sort of analysis, now you're doing a horizontal analysis. You're looking at all the people who tested positive versus all the people who tested negative. Okay? It's kind of the difference there, how the denominators change up, okay? So using this case here, using the results, we'd say the positive predictive value for that test was 80, meaning 12 out of 15 people. So if they had actual disease, 80% of those people would be picked up there, right? Or if someone had that tested positive, 80% probability that they actually have the disease in question, okay? Now would you stop there and say, nope, you have the disease? Probably not. You probably need to do further confirmatory testing. The negative predictive value ended up being around 88%. Again, not great. Like these numbers would be a lot higher if possible. And so why are the values so low, do you think? Well, if you're looking at it, again, if it was 100% correct every single time, it would be 100%, right? If there's no false positive or false negatives. But you end up finding that sometimes by using things like prior knowledge of like what the incidence of disease or prevalence of disease in the population, that's going to be in the next lecture we'll talk about a little bit. But you're ultimately going to find that just medical tests are never really perfect as they're done. And so looking at this, by using that prevalence, it can be really helpful to give us an idea of kind of how many false positive and negative we should be expecting there. Anyway, we mentioned prevalence as just being basically the number of people with disease divided by the total. We've already mentioned that already. But imagine if you were to deal with, say, a condition that only had a 1% prevalence in the population, right? And so that means that after every 100 people tested, that only one of them should come back positive, right? If we had a perfect test. Well, what would happen if we had a 5% false positive error rate? We still did in that same 100 people. Well, 5% of the 99 people without disease would show positive as well, right? Because it's a false positive error rate, which means out of that group, you'd have 6 positive test results, and 5 of them are erroneous. Is that great? Not great, right? So that's something that happens at a fairly low sort of prevalence there. It actually changes up quite a bit if you have something with a very high prevalence. And this is actually where we can use multiple tests sequentially to kind of help us and get a better idea of how likely it is the patient actually has the disease there. So whenever we're doing or testing for rare conditions, you have to be prepared that a lot of those positive results may be falsely positive, right? That's why you have to do further confirmatory testing there. And so you don't want to just hang your hat on just a single sort of laboratory test in those cases there. However, it can be useful for screening, right? It can be useful to try to do an easy way of screening to see, okay, well, do I need to do further investigation or not? And so while a laboratory test may be kind of involved, it may be as simple as just saying, hey, have you been, say for instance, you're screening for Ebola at the check-in desk at a ER, for instance, right? And they can ask questions like, hey, have you been to, say, Sierra Leone or the Democratic Republic of Congo recently? Just because they say yes to that, does that mean they automatically have Ebola? No, there's probably a lot of false positive error rates there. So because of that, but that does at least, it's easy to do. And you can take those people as initial screening and then do confirmatory testing as a follow-up, right? So that's why the screening programs can be somewhat useful in those cases there. One thing to note, though, is that unless a test is considered to be pathognomonic, you need to do further follow-up testing. When I say pathognomonic, what does that mean? Super specific to that. So if it's positive, that means yes, you absolutely have the disease there. Okay. Again, not a ton of them are out there, but in some cases you may run into that. Okay. So now let's talk about ruling out or ruling in disease. Okay, you guys ever heard of spin and snout? Okay, so this is a means of kind of you ordering sequential lab tests in order to kind of work up your patient to determine, am I done here, right? Or do I need to do more testing, okay? So let's say a patient comes in, they complain of chest pain, right? Can you just look at them and say, you have a heart attack? No, right? So you come up with a differential, right? So what else could it be? PE, musculoskeletal pain. We can always say cancer, right? Could be cancer, who knows, right? Could be lupus, right? Who could say? Getting into it though, you work up your differential, right? So you want to start out by doing things that can rule out really easy diagnoses, right? So for instance, to rule out, say, an MI in that patient with chest pain, what do? It's quick and easy. EKG, right? You can just look at the EKG and say, nope, doesn't look like a heart attack. Done, right? So those are going to be things that are going to be good to rule out and get rid of or discard sort of false hypotheses. Because every time you're working up a patient with different differentials, you say, okay, well, I hypothesize that this could be a PE, and then you do your testing and you say, okay, that's either it, or you discard it, right? And then you move on with your day. So this is where we're going to be looking at sort of easy things you can do up front to try to screen or rule out and discard some of these false hypotheses, right? So you're going to find that the initial test should be highly sensitive. Okay, now why is that?
So it's on your radar.
Right, you want to cast a wide net, and it's okay if you get a false positive early on, because you at least want to do further confirmatory testing. Would you want to miss an MI in a patient? Typically no, right? So you want to make sure they're using something that's going to be highly sensitive, so that way even if it's maybe marginal, you can at least do further follow-up testing, right? Because what would you order, say, after you got the EKG back? You're not really sure. What do you check? Check your troponins, right? You can do further follow-up testing on that sort of thing. But you want something that's going to be highly sensitive in order to do that, right? So that way you kind of keep everything up on your radar. You want to only rule out things that if it's negative, it means it's super unlikely to be it, right? So what you're going to find is that with tests with high degree of sensitivity, they have a really low false negative error rate, such that it's low false negative error rate. That means that if it's really negative, then you know it's going to be negative in that case there. That's why you just kind of rule out those disease cases there. That means that not many true cases of disease are going to be missed, okay? So again, you're casting a wide net early, and they can then tighten up later on. So you don't want false positive error results, but they're going to be tolerable at the very early portion of the workup, okay? So then once you kind of start to get rid of sort of like the zebra sort of diagnoses, and you're kind of working out some of those things based on the tests you have, next thing you want to do is consider to be ruling in or confirming your actual true diagnosis, okay? So initially you want to rule stuff out, and then you want to eventually rule stuff in to say, okay, this is my final diagnosis, right? And so these you're going to find tend to be very specific tests, okay? So when it's very specific, that means that the patient's negative, that means they're really negative, okay? So you're going to find that tests with a high degree of specificity may have a small false positive error rate, such that if they do come back positive, you know, it's not going to be because of some other disease state, it's actually because of what you really think it is. And so even though you don't want to treat those patients for disease they do not have, again, because it could make a decision whether it's surgical or medical, etc. And so again, using a highly specific test as a follow-up is going to help you to actually make sure that if that patient does come back positive, that that is truly the case there, they have that disease there. So it kind of goes with spin and snout. So to rule things out, you want highly sensitive tests, and for to rule things in, you want highly specific tests. Okay? So just remember spin and snout. They'll usually get you most of the way. Okay? So the snout, you want highly sensitive tests early on, because when you cast a wide net such that they're really negative, they definitely don't have the disease, because you're sure to catch almost everybody, even if they really don't have it, because there's so many false positives. On the flip side of that, when you're ready to rule that final thing in, it's something really highly specific, such that once they're positive, you know, yes, they definitely do have that disease. Okay? It's okay. You can come to my office, we can talk about it, and it usually happens at least once a year. Anyway, continuing on though, getting into likelihood ratios, odds ratios, and then cutoff points, right? So kind of determining how we are really going to be setting these points here to say what's the right cutoff point for our test here. So as opposed to predictive values, you're going to find likelihood ratios are not going to be influenced by that prevalence of disease, right? Because we mentioned if you have, say, something that only comes up 1% of the time in your patients, you're going to get a lot of false positives, because those tests, again, are not 100% sensitive or specific in most cases. So what we can do, though, is get a likelihood ratio that will look at the sensitivity of the test to the false positive error rate of the test, and it will give us to say that if they're positive, what the likelihood they actually have that actual disease there. And basically it takes out the issue of prevalence in a lot of cases. Normally what you're going to find is that the higher the number is, the greater, higher than 1 it is, the more likelihood that means that a patient actually has that disease when that comes back with a positive result there. Typically you want really large likelihood ratios, right? If it was like 1.2, it means it's not great, but it would be, the higher that ratio gets, the better it's performing, okay? So you want a high positive likelihood ratio, because that means that the actual true number of cases you have is much, much, much higher than the number of false positives you have there. Oops. On the flip side, though, you also have the likelihood negative ratio, and so here you're going to be looking at the ratio of false negative error rates divided by the specificity, and for this one here, you typically want a pretty small value, okay? So you want a small negative likelihood ratio, and then you want a really high positive likelihood ratio, and by comparing those two together, you'll see that you're getting a pretty good test here. So the closer to 0 the negative likelihood ratio gets, the better it's performing. So in this case here, we can use it with our hypothetical calcium example, and we see the sensitivity we saw was 60%, and so looking at this, our false positive error rate, which is basically another way to calculate, that's 1 minus specificity, is going to end up being 3 over 60 or 5%. Okay, so that means when we get the likelihood ratio, it's going to be 0.6 divided by 0.05, it's going to be 12. Okay, so that means performing pretty well, but maybe not as high as we would like. Okay, usually around 50 or so, 50 or higher is considered to be a pretty good likelihood ratio in those cases there, which makes sense because again, this is not a very highly sensitive test. It's not great. It's good for initial screening, but not good for diagnosis. And so you still see though you're getting 40% of those people actually being missed, which is kind of the problem with these. If you do the likelihood negative ratio here, you're going to see that that would actually calculate to be 0.421, and it's actually a lot larger than you'd want. You want that as close to 0 as you can to show that yes, if they're negative, that means that they're truly negative on the case. And so here you can see that they're doing this ratio between the likelihood ratio positive to negative, and the higher this is, the better it's going to be. So usually less than 50 considers a pretty weak test, but that's okay, right? Because you can do follow-up testing with the parathyroid level, things like that. Okay, so in this case here, you can try to say, well, what would happen if I changed my cutoff points? What if I say instead of using 11, maybe I use 13 instead, right? And so here you're going to find that by increasing that cutoff point, what does that do to my sensitivity? It decreases it because I'm catching fewer of those people that may actually have the disease just because they had a relatively low level there. And so you're going to find that your true positive results are going to be eliminated usually at a slower rate than the false positive rates there. And so you may actually find that likelihood ratio positive actually gets a little bit better in those cases there. The point is to find that kind of like Goldilocks zone where you're going to be at the right spot where it's not to be too stringent, but it's also not too lax in those cases there. Okay. Again, if you use an extremely low level, you're going to find that almost everyone's going to get diagnosed with the disease, and that's not really going to be all that useful to you. Okay. We're not going to talk about receiver operating characteristic curves. I thought I removed that slide, but that was it. So anyway, so that's pretty much it in terms of looking at lab tests. Remember that you want to use really sensitive or specific tests early on. Or you want to snout. So sensitive tests to rule things out, such that if they are negative, then they are truly negative, most likely. And then to rule things in, you want things that are highly specific, such that when they do get that positive result, then that means yes, they really do have the disease there. Okay. Any questions that I can answer? I guess I'll let you go 10 minutes early. Oh, can you tell us your poison stories? Yes, Peppa will tell you your poison stories. I don't know if anyone actually wants to hear that or not, but I did have one case, I'll share this one with you, where the specialist called me up and they basically had a lady who had ingested, say 40 of her lithium tablets. Does anyone know if lithium's like bad ingestion or not? It is real bad, it's not great. So anyway, so just kind of to show you the disparities between the resources at a hospital. So for instance, the thing that I would do, because sometimes, you know, if a patient who is stating they're trying to harm themselves, are they always going to be the most honest patients you're dealing with? No. A way that we tell if they're lying or not is if we look to see, we do the lip test, and if they're moving, then we assume they're lying, right? Only slightly cynical, but point being is that I said, well, what was the lithium level? And keep in mind, they're like at this like really podunk hospital, like out in the middle of nowhere, and they said, oh, well, it's a send out. It's going to take 2 or 3 days. And I said, well, the patients either will have recovered or be dead by then. So what's going on? What are we going to do with that patient, right? He said, I don't know. They said it's going to be 2 or 3 days. I said, okay. And I said, well, should we do whole bowel irrigation. So sometimes for certain ingestions, what we'll actually do is called whole bowel irrigation, where you guys are familiar with Go Lightly. Ever heard of that? Or Miralax? Basically, it means it's a laxative you can give usually through an NG tube to basically flush out the entire GI tract to get any of that lithium that's still in there to flush it right out. Okay, it's really labor intensive. Most patients don't like to do it, and they won't really be all that cooperative with it, which is why you put the NG tube down. But also, imagine if a patient starts seizing, they might aspirate, they get all that Go Lightly down in their lungs. It's no great shakes. I've been doing this for, I don't know, maybe 8 years now in Poison Center. You know how many times I've seen whole bowel irrigation done correctly? Like once. Like, no, everyone recommends it, but no one can actually do it right. And again, no nurses want to sit there and make sure the patient drinks. You can like do up to like 2 liters an hour of this stuff. It's bad. So anyway, so he's like, well, do you want me to do whole bowel irrigation? And I said, they can't even get a lithium level. What do you think the likelihood they're actually going to get this whole bowel irrigation done? He's like, yeah, I guess you're right. So then what do? Then we got to recommend transfer to another hospital. We say, well, if she can't receive definitive care there, because potentially may even need up to dialysis for a lithium ingestion, you got to give them out to somewhere where they can get definitive care there. So that's what we ultimately recommend is that, okay, well, you know, you need to, where you're at is not going to be able to provide the care you need to get somewhere else. And so again, that's still a costly sort of intervention, right? Because then you got transport costs to figure into that. So we're making big decisions here. It's important to make sure you think through all the processes there to make sure you're making a good informed decision for your patient's benefit. I'll never forget my first call that I ever had when I was on call. And of course, like my attending at the time was like in the bathroom and I couldn't find him for like an hour. Not great. But it was again another lady at a podunk hospital who had ingested a ton of aspirin. Aspirin's also a really bad one. And they're like, oh, well, if we want to get her to this place to get dialysis, we got a life flighter. And I was like, oh gosh, I got to decide whether the person needs to go in a helicopter. That's a big deal. Like, it's a helicopter. And said, yes, do it. And then I was like, I pray that was the right decision. And then the attending's like, yeah, it's good. You're fine. So, but anyway, so those are big decisions you have to make sometimes. Any other questions? If not, I will talk to you guys next time.